Hello everyone, my name is Zach Hansen. I'm a physician assistant working alongside Dr. Kurtis Staples for Sonoran Orthopedic Trauma Surgeons in Phoenix, Arizona. Today, we are demonstrating pelvic ring fixation using stealth navigation. This is a technique used to help guide the surgical placement of screws. The main indication for using stealth navigation in our practice are 1. Excessive bowel gas, and 2. Extremely small or tight corridors of bone in the sacrum, making surgery difficult with just C-arm for guidance.
We begin by placing a post into the ilium. Attached to this post is an array with orbs that are detected by the navigation system. These orbs must be visible to the camera at all times to ensure accurate directional readings to guide hardware placement. With the array in place, we position a drape over the patient. We use this drape to keep our surgical field sterile because we next bring in an imaging device called the O-arm to capture an intraoperative CT scan. The O-arm is not sterile, which is why we need the drape to protect our working area. The O-arm is positioned next to the patient and the arm closes to form a complete circle. CT imaging is then performed and directly uploaded to the stealth navigation computer. With the CT obtained, we can now adjust and position the pelvic images to give us the trajectory and views we need.
The seat gonna work. No, that's upside down. Now turn it. Keep going. Yeah, that's perfect. Because then we have our inlet and our outlet in here, right? Kind of look. Okay.
Using a drill guide probe with another set of array orbs attached to it, we can now view the exact path of our implant. We fine-tune our movements to ensure that we avoid the risky anatomic structures where crucial nerves exit to help the lower extremities function. The thick yellow line on the screen can be adjusted to provide insight into multiple measurements. We can widen the line to give us the visual of the diameter of the screw in the bone corridor. Additionally, we can adjust the length of this guide line to provide an assessment of length across the sacrum. Once we have a trajectory that is within a safe bone passage in the sacrum, we insert a wire through the guide. As this wire advances in the posterior pelvis, we can feel the resistance in the bone as we pass through the initial cortex of the bone, the SI joint, the fractured zone, the SI joint on the other side, and then the cortex of the bone on the far side. Once we've reached the far cortex, we finish advancing the wire. Not shown here, but given the fracture pattern, we performed the exact same process to place a second wire into the sacrum. This allows for more robust fixation of the pelvis. While the O-arm and the stealth navigation system helped with the initial planning and placement of the wire, we bring in the C-arm to obtain a confirmatory real-time image for the location of the wires.
That's probably a pretty good inlet there. Save that. So we're safe there, for sure. And then how many is that? Is that 25?
Yeah, right about.
So come to 45 now the other way.
With everything in satisfactory position, we insert the screws directly over the wires. These screws have great cutting flutes, which means that we don't need to pre-drill before the screws go in. We sink these screws down to bone and can now remove the guide wires. We get final x-rays of the pelvis to assess our work and begin the process of closing the small incisions on the patient's side with sutures. Given the severity of many posterior ring fractures, patients will often have weight-bearing restrictions placed on them to allow for adequate healing prior to stressing the area.
Thanks for joining us on this walkthrough. Make sure to subscribe to the channel for more point of view insights into the orthopedic trauma OR.